Hello everybody, I'm Saurabh Malhotra from Cook County Health in Chicago, Illinois. I am a imaging cardiologist. I'm a director of advanced cardiac imaging and cardiac amyloidosis at Cook County Health. Here in Mumbai at the World Congress of Cardiac Imaging and Clinical Cardiology, I wanted to highlight the importance of nuclear scintigraphy in diagnosis of cardiac amyloidosis. Radionuclide imaging plays a critical role in diagnosis of cardiac amyloidosis, which is now being recognized with increasing prevalence, not just in the Western world, but in India as well. I've met several colleagues here who have done an exceptional job in standardizing their imaging practices using PYP scintigraphy or scintigraphy with similar tracers. Previously, we used to think that planar imaging is sufficient for diagnosis of ATTR, cardiac amyloidosis, but recent studies have suggested that is not the case, and reliance on planar imaging alone can result in significant false positive and false negative cases in a significant number of patients, and thus it is not a diagnostic standard. Tomographic imaging and reconstruction with SPECT or SPECT-CT, if available, should be performed in all cases referred for scintigraphy for cardiac amyloidosis. It must be remembered that a diagnosis of ATTR cardiac amyloidosis cannot be confirmed unless light chain amyloidosis has been concomitantly ruled out, and I recommend simultaneous assessment of both light chain disease with assessment of paraproteinemia in the serum and urine, and performance of nuclear scintigraphy with either PYP, DPD, or HDP as availability allows. Studies have shown that markedly positive scintigraphy results, such as grade 2 or 3 visual scores, can be present in up to 10% of patients with light chain disease, and those with a visual score of 1 on SPECT. If light chain disease is not ruled out, we may misclassify those patients as TTR amyloidosis. So it is extremely essential to make sure that light chain disease is ruled out, because it's a hematologic emergency, and the treatment of light chain disease varies vastly when compared to transthyretin amyloidosis. In addition, I want to highlight the role genetic testing plays, and no diagnosis for ATTR amyloidosis is complete without genetic testing. What we employ is a shotgun approach. If there is a patient who is sent to us with a high clinical suspicion of cardiac amyloidosis, we not only rule out light chain disease, perform nuclear scintigraphy, but also perform genetic testing, because in our population where we work in Chicago, Illinois, there is a large proportion of V122I mutation. So we see a lot of patients with hereditary amyloidosis. Many of them may not have cardiac involvement yet, but amyloidosis happens to be a systemic disease with cardiac manifestations typically occurring later in the disease. So a wholesome approach to diagnosis of amyloidosis and cardiac amyloidosis would be performance of nuclear scintigraphy, ruling out light chain disease, and performing genetic testing. Thank you.